Welcome to this instructional video demonstrating an efficient and safe method for accessing the subacromial space during shoulder arthroscopy, specifically utilizing a rigid cannula technique. The subacromial space can present considerable challenges due to its confined anatomy. Frequently, inflamed and thickened bursal tissue limits visualization and increases the risk of inadvertent trauma to the rotator cuff tendons. Additionally, intraoperative swelling further complicates accurate navigation within this critical area. Standard procedures are followed for room and patient setup and instrument selection. Here we see right shoulder in beach chair position. 3 portals are used for this procedure. Posterior portal for visualization, anterior portal for cannula insertion, and lateral portal for decompression and debridement of subacromial space. Following proper establishment of portals and achieving adequate visualization, initially reintroduce the trocar into the metal sheath. The trocar tip palpates the acromion border. A controlled extension-flexion motion of the wrist assists in confirming correct placement beneath the acromion. Next, the trocar sheath is guided anteriorly, maintaining consistent contact with the underside of the acromion to safeguard underlying structures. With tactile palpation, the coracoacromial ligament is precisely identified, ensuring this ligament remains lateral to our entry point. We then introduce the rigid cannula over the trocar sheath, advancing into the subacromial space. The arthroscopic camera is subsequently placed into the cannula, providing immediate clear visualization and confirming safe positioning. Surgical instruments are now easily introduced through the cannula, allowing effective debridement and bursal decompression. Further adjustments of both camera and cannula is performed by gently retracting the cannula while advancing the surgical instrument. The optimal midpoint within the subacromial space is identified when the camera emerges slightly from the cannula's inner sheath. Upon achieving this ideal position, meticulous removal of inflamed bursal tissue can commence, improving visualization and ensuring protection of the rotator cuff. The coracoacromial ligament's proximity confirms correct lateral portal entry, further validating our precise approach. In summary, this rigid cannula-assisted technique streamlines entry into the subacromial space, enhances visualization, reduces risk to the rotator cuff, and facilitates precise surgical intervention.